Dr. Laura Porter is a stage 4 colon cancer survivor and has worked as a patient advocate and a medical advisor for nonprofit organizations for over 17 years. As a research advocate, she is a grant reviewer for several organizations and serves on several committees with ASCO. She is currently a co-investigator on an international grant through Cancer Research United Kingdom, Team Optimistic, which is studying the microbiome and the impact on the development and treatment of colorectal cancer.
Hello, and thank you for that wonderful introduction, Kim. I would like to welcome everybody to the second AllyCon Doctors Meet and Greet panel discussion. And joining me today is Dr. Nilofer Azad. She is a medical oncologist and professor of oncology at Johns Hopkins Sidney Kimmel Comprehensive Cancer Center. Also, Dr. Cedrek McFadden, who is a colorectal surgeon and vice chair of operations, Department of Surgery, Prisma Health, assistant professor of surgery, University of South Carolina School of Medicine, Greenville. And again, for the second day, thank you, Dr. John Marshall, who is a medical oncologist at Lombardi Comprehensive Cancer Center, Georgetown University Medical Center, and the chief of hematology and oncology. Thank you all for joining me today. As we did yesterday, we have questions that came in prior to the prior to the meeting. But what we'd like to start with today are some kind of personal questions. The first question, and you can tie both of these in together, why did you choose your specialty? And being in oncology, what do you do for self-care? How do you prevent yourself from becoming too involved or too burned out? So Dr. Azad, would you like to start for us?
Absolutely. So I trained in Texas, in Houston, and I was in medical school in my second year of medical school, and I did my first rotation, which was actually pediatric oncology, very first clinical rotation. And I was pretty hooked at that point, just in terms of the way that people got to know each other's families, and then the science behind oncology. But I also knew that pediatrics wasn't really where my heart was. And so as I did internal medicine, which is oncology's subspecialty of, and I kind of knew in my bones from the very beginning. I think that it's an amazing field that we get to be in. We get to know people's families very well. We get to know patients very well over a long time, but we're still taking care of a serious illness. And so the depth of that relationship, I think, is different when you're taking care of serious illnesses. And on top of that, the science has been so groundbreaking. And I think I knew that even as a medical student and as a resident, that we were going to see the kinds of openings in science that we have over the last decade. I've got to admit, I don't have a lot of hobbies. My husband and I joke about this. He's the hobby guy. And I'm the person that really enjoys spending time with people. And that's really what I do for self-care. I really do prioritize spending time both with my family, my kids, but my friends and my larger social circle. And that gives me a lot of contentedness.
Thank you. Dr. McFadden?
So I was one of the kids probably in high school that knew I wanted to do medicine. And I entered medical school. I went to Temple in Philadelphia. And I was immediately enthralled with clinical rotations. And the first rotation I did was surgery. And although my initial plans were not to become a surgeon, it was the rotation that I think set the bar. It set it high. I often joke that if my initial rotation was pathology, I might be a pathologist today. But nevertheless, surgery I fell in love with. There was an attending which really he was a general surgeon, but did a lot of colorectal work, a lot of patients with Crohn's disease. And I just saw the compassion that he had for people that had really tough problems. And I think it set the tone for what I wanted my career to be. And even though he was a general surgeon, did lots of colorectal, it really brought my interest to colorectal And as I've grown into the space, I've understood more about the depth and the quality that I could have on people with colorectal illnesses, such as colorectal cancer, and the quality of their life. So it really was a no-brainer to me. The camaraderie that's in surgery, the actual doing, the actual, taking a cancer out. There's no better feeling I've ever had. It was, removing a cancer. And that's just a phenomenal feeling. It's like that drug you want to just kind of keep having that experience. So I continue to be in love with what I do on a daily basis. For self-care, I continue to work toward finding ways to be creative. I do that in a number of ways. I sing at my church, and I sing quite frequently, and I enjoy that. And that's a really great release for me. But I also run, and I spend a lot of time running and putting mileage on shoes. And that's just a time to think, a time to regroup, and to really process whatever may be going on a daily basis. So that's how I primarily have self-care. I also have a 15 and a 7-year-old. If you know anything about kids, that keeps you quite busy, and it puts things in perspective for you on many levels. So that's a big way in which I practice self-care, is just, working with my family as well.
Thank you very much. Dr. Marshall?
I want to hear a song myself.
I know.
A little "How Great Thou Art" would really set my day well today. Actually,
Not today. Not today.
It's a Sunday thing. I think most oncology people have a calling of some sort or another. I think we heard from my colleagues that they were sort of drawn to it, and so when I'm now interviewing young people looking at the field, one of the things I try and assess is, what is your calling? Because it is an intense world that you really have to feel drawn towards to do it. My calling was, I cut my teeth on it as a kid, going to radiation appointments and chemo appointments with my mom when she had lymphoma back in the 70s, and ultimately dies of non-Hodgkin's lymphoma. So I always attribute my interest there. But it's interesting how something like that can affect different people at different stages. I was sort of the science geek, and I thought, I'm going to cure cancer, whereas my brother decided to sue doctors for a living. So, you each take he was pissed and was going to deal with it in a different way. In terms of, choosing a GI oncology, for example, I think it kind of chose me. I was into drug development, and when I joined here at Georgetown a whole long time ago, that was the job that was open. I wanted to do solid tumors where there was something going on in terms of new drug development, and they're like, how about GI? Because at the time, of course, there was only one drug for almost all of the GI cancers, and it was ripe for that. So I always think that colorectal cancer and GI cancer kind of chose me more than anything. In terms of managing health and mental well-being, I'm not the right example, because I did not do it well. I am publicly out there as having burned out, quite honestly, about 2 years ago, taking a sabbatical from work. It's complicated. The story about burnout is complicated. My wife and I, in fact, part of my therapy was that she went along with writing a book about the whole damn thing, which is out now. But it really addresses the subtleties of that question, is that how do we manage the balance between caring deeply for our patients and not taking everybody's bad scan home with us, not feeling everybody's either death or a bad outcome. If you're really a caring human being and a good doc, you've already you've merged with them on some level. So we can't be both effective and highly objective. But if we lose our objectivity, we eventually suffer from burnout. So bourbon was a good answer for a while, I would have to say, but not until after 6. And then, but things like exercise and keep moving and going to plays and writing an occasional book. That's how I've tried to deal with it.
Thank you very much. Very enlightening. Thank you all. So let's start with, let's continue with the individual, when a patient first comes to you and they have newly diagnosed colorectal cancer, so what kind of information do you give them? I know this is a very general question. It came in, I think, yesterday. Do you give them specific information for them, general information? I realize that you probably don't have specific information until after, like, biomarker testing or genetic testing is done. But, so if you could just talk about that, that would be helpful. Thank you. Dr. Marshall, do you want to start with that?
Sure. I mean, if I'm the first oncologist, right? So it depends on how much they've already heard. Rarely are we the ones who are telling them the diagnosis. They already know the diagnosis. They don't know necessarily what it means or the context of it. If they've seen a great surgeon who's already gone through things with them, then they have a sense of why they're coming to see us, and they've already started to click around a little bit. But for a first visit, what I try to do is assess, what do they know? Who else knows they're there? And what are how much of their, what are their other major medical issues that will affect what we're going to do? And in what is really a very quick hour, some take longer, you try and get them up to speed with what's going on. How serious is the diagnosis? Are we thinking about curing you or not? What is your life going to look like over the next week to month, and then longer? What's it going to look like over the next 6 months plus? And because I think they're not hearing the details on a first visit. So I tend to stay fairly high on the arc of data. Now, if you're the second or third oncologist, you can skip a lot of that and get into the weeds of things much quicker. But you have to read your audience. What do they know? What don't they know? What do they want to hear? What don't they want to hear? And what they can take in, so that you can move the bar forward in their treatment. I'd be very interested to see what the others say to this.
Thank you. Dr. McFadden?
Well, I just had a conversation this morning in this exact same scenario, actually a couple. And I think one of the big goals as a surgeon, if I've not diagnosed the cancer and they're present to talk about their surgical options, a big goal that I have is to set clear expectations. We talk about what's surgery like, how is that going to impact their life? And really, one of the big questions, regardless of the cancer, regardless of the problem or the situation, one of the biggest questions that's often unspoken until I bring it up is, will they need to have a colostomy? That is one of the dreaded things that I always feel that patients come in with that background is, will I need the bag? And I think I've tended over the years to incorporate that in what we speak about in that first visit, obviously. But for me as a surgeon, it's important to set clear expectations about, the benefits, the potential complications, and the problems that we could have with surgery, and really setting very clear expectations of all of that. And then giving them the overall sense, depending on where they've seen me in their course of conversations about their cancer, about what could happen afterwards, whether or not they're going to meet the oncologist, what survivorship plans may look like. And I really try to allow the oncologist to have their moment. So I basically manage them up, the team that I work with. And really, over the years, I've had that relationship to where I know what their spell is going to be, but we also give them that conversation that they're going to have with the oncologist. But for me, it's all about setting expectations, talking about what surgery may or may not look like and what problems they could have afterwards, and how that fits into the overall plan of going for cure.
Thank you. I think that also goes, I'll get to you in a minute, Dr. Azad, but I think that also goes along with the, the multidisciplinary team and how important that is in managing colorectal cancer. So so I'll let you, thank you, Dr. Azad.
Yeah, I would say my first visit with patients is the most general that a visit is that I ever have with a given patient. And that's still 50-50. So 50% of that visit is probably still very much tailored towards that person's individual circumstance, what we know about the pathology of their cancer, the biomarkers that they have, and the treatment plan that we're going to start moving forward with. But when I say general, the other 50% is kind of broad brushstrokes about colon cancer, and where even people who come in and see us, as a major referral center, we see a lot of people in the third or fourth line of therapy. So they've had this disease for some time. They're coming to see us. They have a lot of knowledge overall, but we're still trying to get to know them. So I really want to pick up on that piece that John said, is that every patient is so different. And there are some folks that really want, they want the worst case scenario so they can prepare for it. And there are some patients that really only want to focus on the best case scenario. And I have a little bit of the benefit of being a consultant for so many patients, because I think often when patients are disappointed or unhappy with communication with their primary team, it's really that person was the first person that spoke to them about some of these realities. And it's not that doctor wasn't caring or that doctor was trying to give up hope. I have a lot of people that come in and say, my doctor says there's nothing else left for me. And I don't think that that's usually how most oncologists are talking to them. And I have the benefit of being the second person that's talking to them. So for this audience, the thing that I think is really important is just that we're always trying to figure out how best to talk about some of these difficult issues, and we never get it right every time. And so if the more that you can give people the benefit of the doubt that they are working in your best interest and are just trying to find ways to communicate challenging situations, I think the better people will feel cared for overall.
Thank you.
Can I jump in
very
there
much.
for a second, Dr. Porter?
Sure.
I think a challenge that people have coming into a surgeon's office, especially if they've had any work from a colonoscopy or either a surgical procedure already, and they're coming to me as a second opinion, either after a complication. I think her point is very well taken, is that sometimes being the second person that's looked at a case, you can play Monday morning quarterback a little bit. And I think it's a little bit of a disadvantage for that first provider, depending on the complexity of the case. And so I do think we have a duty to make sure we're being very clear about what potential complications could be, especially when we talk about surgery for these very complex cases.
Thank you. Yes. So that leads me to my next question. We have some questions about LARS syndrome, LARS syndrome. And this person has said that they haven't been changing their diet, but some days are worse than ever and the symptoms come and go. So if you could first, we touched on this yesterday, but if you could first just give a little definition of LARS, what kind of surgery that is, and then the side effects and what people could possibly do to help with those. That would be great, Dr. McFadden.
So the lower interior resection syndrome, you have, after having a distal or a rectal cancer that's, below 7 centimeters, 6 centimeters, after a resection with sort of sparing of the sphincters, you can exhibit challenges with several aspects of your postoperative care. You can have problems with, your continence and how well you can control stool, or what we like to call anal seepage or soilage. You can also have problems with urgency, extra flatulence, or bloating. And there can be some difficulty controlling, especially after being out for dinner, how quickly you have to get to the restroom. And it can really impact a person's life after surgery in ways that go beyond just trying to cure their cancer. They start to have to, I think there's a phase after surgery where people accept, okay, I've had surgery, I've gotten over it, I need chemo, I don't need chemo, I'm finished with it, et cetera. But then there's the life that they have to lead. And 25 to 80%, which is a very wide range of patients, will exhibit some form of this type of issue after surgery. And in fact, even 10 years out, nearly half of our patients will still have some of these symptoms. So again, it goes back to kind of setting the expectation. And there are things that people have been instructed to do that may be beneficial, from bulking the stool, from firming the stool, to eliminating certain things from the diet that may make those symptoms worse, such as milk or dairy products. perhaps staying away from leafy vegetables or crunchy vegetables, whether it be, from cabbage to, celery, et cetera, that can make that bloating and create more of an issue with seepage, to even having them incorporate other foods into their diet, such as breads or marshmallows or bananas, things that may give them a little bit more bulk, and the incorporation of fiber products. I think that patients come to know really quickly what things they can do and what they can't do. The challenge is, like this question says, is what happens when I'm doing all the right things and I'm still having this fluctuations? And I come back to tell patients it's like life, right? Sometimes you do all the right things and then not so good results happen. Some of that could be dictated by your emotions, your activity, what's going on at work, what's going on at home, if you have more anxiety. All those things can affect how you process food and how you then have results, especially from this type of a syndrome. So I often remind patients, if we have a plan, stay with that plan and have options to adapt and to add to that plan. So not to give up hope, not to abandon everything that you've already been incorporating, but to have ways, perhaps if you are using, say, FiberCon, or you're using the Metamucil wafers, which I recommend is actually a really good thing to use, taking it, 2 to 4 of them a day, have something good on top of that. You have success with that initially. Well, perhaps there are days that we're going to have to add a little bit of Imodium or Lamodal on top of that fiber, but don't abandon the current plan just because today it's a little bit different. Stay with the plan, but have ways in which we can add extra things to it. And often that's just with fiber, but additionally having a team that can escalate when necessary, whether that be with a good pelvic floor therapist or a surgeon that can talk about other options such as sacral nerve stimulation. There may be other pieces that you have to add to it, but having the plan and having pieces that we can add or take away when needed.
Thank you very much. Dr. Marshall or Dr. Azad?
Well, I'll add sort of maybe kind of a not sad, but bleaker look at some patients who have done all the right things. And because surgery has gotten so good at reanastomosis at very low down, and there are a lot of people who don't have significant amount of bowel to store and process, then it's just really, despite doing all the right things, they become prisoners of their homes and really don't feel comfortable. They know where all the Nordstrom bathrooms are across the city. And I've had a few in 25 plus years of practice, patients who just decided that an ostomy was a better thing to do. And I know we have this social stigma around, I get it, right? Totally, why? I always tell my patients, I can't tell who has got one or not. I don't do it till I examine their abdomen. Do I remember who has one or not? But that can become, usually out of desperation, I will have to say, but it can become an option that does give you back the control and social control that you have if you really can't, if the strategies that we have to offer you are not working. It's not common. As I said, it's only happened a few times in my 20-something years, but it just to put out there that some people do opt for it.
And I think thinking of it as a continuum of care, to where it's not a sign of failure. It may be the ultimate goal or the decision that's made, but it's along a continuum as opposed to a defined failure.
Well put. Well put.
Dr. Azad, do you have anything to add?
No, I think that that my two colleagues have done a great job talking about this, and I think Dr. McFadden's points in particular are they're very meaningful, as surgeons are often the first line of defense about this. The two things I'll just reiterate that I think you mentioned, Cedrek, is that things change day by day, and it takes a while for your bowels to settle into the pattern they're going to be in. So 6 months, even a year down the road, is really where you're going to know where you live. And just like before a person had colon cancer, there are days where your bowels are just not behaving as well. And there are days where you might get constipated, and there are days you might have loose stools. Even without colon cancer, that will be true, but it'll just feel bigger and more challenging without a rectum. So, but that part is a normal part of life that, different days people feel differently when it comes to that issue.
Thank you. So someone else posted that they had just had surgery and a resection, and they want to know before they start chemo how they can gain weight without eating unhealthy fats and sugars. So I guess besides Ensure, is there a way to gain weight? Who would like to take that?
So I'd love to chat about that really quickly. So one of the things that I tell my patients when they come out of a surgery and they're coming to us is realistic expectations. So it's not realistic to expect that you're going to get back to your fighting weight. Many people have lost some weight even before their diagnosis, when they are recovering from surgery and when they're on chemotherapy. So really what we should be focusing on that time is maintenance of weight. And if we can maintain, then we're looking at the long game here. So there will be time for those things to happen. But if you're about to start your adjuvant chemotherapy and you're just a few weeks from your last surgery, it's all right to maintain your weight during that time period and work on gaining weight once that piece is done. The metastatic setting, that's a little bit more challenging if you're going to be on chemotherapy off and on. And so while they're meeting with nutritionists and thinking about thoughtful eating, supplements, all of those are going to be a part of your paradigm. But for someone who's undergoing adjuvant therapy, it's really just a little bit of waiting for the right time to start working on that goal.
I think patients are sometimes discouraged about their lack of appetite or fatigue after any surgery. There's a period of time where your appetite, you don't have the really incentive to eat, you don't want to eat, and very few bites. Even though as a colorectal surgeon, I'm not doing any formal gastric resection, people will say, I ate 3 bites of food and I feel full. I've not taken any part of their stomach during their surgery, but it's this sort of perception of kind of how they're said, how full they get and how quickly they get full. And I think having that honest conversation to say, eat what you can, and as long as you're keeping things down, it's focusing on the right things to eat and what you can tolerate. So whether that be the really good proteins to have, and whether that be focusing on making sure you're staying hydrated, those are the primary goals that I set after surgery in my patients.
I was latching on to the unhealthy fats. I don't know what that is. So I think a diagnosis of cancer is often a moment when many people decide that they're going to completely change how they eat.
Yes.
Whatever it was before, it was wrong. That's why I got cancer. And now I'm going to do something different. And it's fascinating, and patients may not see this, but the 3 of us see it all the time, is that one patient's totally convinced that this is the correct diet, and the next patient will be totally convinced that some other diet is the correct. And so, through the course of a day, we might hear about 8 different diets that are totally the right thing and anything else is wrong. I think there's a lot to nutrition science. But there's also a lot we do not know. And so early on, just as Dr. Azad said, I sort of emphasize, just try not to lose any weight right now. If that means you're going to get some Ben and Jerry's every night, well, have fun with it. And then think about nutrition as a longer arc here. And if you're going to make some changes to your diet, make sure you're getting all the key elements in it. Remembering that everything you eat, you convert to sugar on some level. So, I get reducing, free sugar in your diet, but you can't really. This is what I say to patients, though, this is not the time to make a dramatic change. You can over time, that's fine, but don't do it on a dime.
I actually offer patients, as a part of our team, we have a nutritionist. And so I will offer patients a consultation with our nutritionist after they've gotten home, especially if they're having these types of questions, because like Dr. Marshall said, there's so much science behind nutrition. I like to make sure they have as much information as they can handle or requesting that can help them make the best decision. So it's often a part of my post-operative plan is, would you like to see the nutritionist as you're recovering from your surgery?
And just a quick comment to caregivers, because I think a lot of the time this is actually coming more from caregivers, because this is how we show love, right? We show love by taking care of people and by feeding them. And so I think the more pressure that you can take off of people about their diet and let people, this is a time where people are stressed and unhappy for understandable reasons. So being able to find joy where you can find it, whether it be in the foods that you eat, or the drinks that you drink. I don't tell people they have to stop drinking. I tell them to do everything in moderation, because there's no data to support it, and if there were data to support it, we would all be giving that advice. But the fact is the data doesn't exist. And so focusing on what actually gives you pleasure. I mean, I just love eating, so that's part of my where it's coming from, right? But regardless, I mean, and to recognize that your family member is actually doing that out of love, but that you can say, I hear you. My doctor is telling me that this isn't actually what I need to do, but I appreciate the affection.
We do a lot of family counseling, don't we?
Yes. Thank you. So there were a couple of questions about surgery. One of them, a patient had their port removed. Obviously, they were considered NED. And now the cancer's come back and they need to have chemo again. Their concern is that their doctor has told them that they don't need a port, but they have not received any chemo without a port. So is there a benefit to having a port? I know for me, I mean, oxaliplatin is pretty bad on the veins, and a port was an excellent way to receive it. So do you all have any input on that? And also, how would they approach their doctor about getting the port put back in?
I always joke that if God had worked all 7 days, we would already have a port, but God took a day off, and therefore we have to borrow the skills of the surgeon or IR doctor to put one in. Oxaliplatin is the major one that really, in our shop, for example, requires a port. We allow some peripheral use, but not long-term. It's hard on the veins, neurologic symptoms and the like. But just the wear and tear for a lot of therapies can be enough to make peripheral IV access more difficult over time. And some of our recipes, if you're getting home 5FU, for example, with a pump, you need a port to deliver that. So yeah, a high proportion of our patients have them, but there are some regimens, some recipes where people don't have to have one. So we try and get by without in those patients who don't want one and don't have to have one.
So basically it's based on what chemotherapy they're going to be receiving.
Yeah, I mean, increasingly there are a lot of oral medicines we use. Some of our medicines are only every few weeks, and they're quicker. Some of the immune therapies don't require it. The bevacizumabs don't require it. But just the repeating, I always think about patients waking up in the morning and think, oh, they've got to find an IV on me, and dreading, coming in while they dig around for an IV. So we tend to have a high proportion of patients who end up getting ports.
And I think at the stem of that question, I hear a patient who has some concerns about how to communicate effectively with their doctor. Yeah. And that's a problem that not even just cancer patients. I mean, that's a repeated issue. And I think we, as physicians, we have to do a better job of making sure our patients can come to us and say, you know what, I heard you say I didn't need one, but I'm not sure I agree with that. Or can you explain to me why that makes sense? Because I think the way Dr. Marshall's just said that, I mean, I would believe whatever he said to me because of just that clearness of that answer. And I think just having patients have that comfort level, and patients knowing that as a physician, we're okay with you asking us. We're okay with you saying, I think I disagree with what you're saying. Maybe if you explain to me, I need clarification. And I think that's the key of feeling okay to not only ask your doctor a question, but also letting your doctor know, I think I disagree with what you're saying. Help me see it, or can we come to a better answer that we both may agree with?
I'll let Nilo go, I'm sure, but I was thinking about situation this morning where I have a patient that I saw on Friday, and we agreed on a new recipe. It had nothing to do with the port, it's back to communication. And I told that patient and his wife that someone from our team would be contacting them about their treatment schedule. And so that turns out to be Thursday. They got an appointment for Thursday to start their treatment. Well, the person who called, not me, said your chemo infusion, well, this was going to be IO therapy. It wasn't going to be chemo. And the patient heard that I'm getting a chemo infusion. And because of the telephone game and the language that was used, that set off like 3 phone calls from the patient. Like, I didn't know I was getting chemo. And so all I had to do was pick up the phone and call and say, no, that's the IO. And well, they said, keep me right. So you can see how sometimes the doctor is saying one thing, but the message that actually makes it through the team and the staff can sometimes get altered. And so that's on us a little bit to do our job communicating, because it can't always be the physician who's communicating the message. We have to be extended through our other team members.
Thank you. Dr. Azad, did you want to?
I don't have anything meaningful to add past what these two guys have already said nicely.
Okay, so now I'll go to questions that I think you're perfect for. Not that you two aren't, but Dr. Azad, these questions are based on clinical trials. So, so I am a firm believer in people looking for clinical trials as soon as they're diagnosed. And the reason is, even though they may not be eligible, or they may still have a lot of different options available, they need to know what's out there. Also, some clinical trials require them to be treatment naive, and this may be beneficial for them. So we had a stage 2 patient who wanted to know if it would be beneficial to sign up for a clinical trial. And I know that this depends on their molecular markers and everything else. But I think part of the question was also, how do I know if I'm getting a placebo or an actual drug? And I think that there's a misconception about clinical trials being important at the end of life, that once you've run out of options, then you find clinical trials, which I think is incorrect. And also that you're not going to get treatment, you're going to get a placebo. So if you could address those issues, I'd appreciate it.
Sure. So I absolutely agree that as soon as we should be thinking about clinical trials for patients at every stage of their journey. The truth, though, in colorectal cancer is that early stage disease, there isn't much when it comes to clinical trials that presently is ongoing nationwide that would be therapeutic. Most of that work is really biomarker based, trying to determine whether, the ctDNA that companies like Natera have been great at marketing, but we actually need to do the trials now to see if that makes a difference, if we check ctDNA early or not. But in terms of new therapies that we're trying to do to improve on, let's say, FOLFOX chemotherapy in stage 2 or stage 3 disease, really in that space, there isn't a lot that's going on nationwide. We don't, for example, have a trial open in that space, except for MSI high patients that have stage 3 disease. So I think it's great to talk about it, but I think in early stage disease, right, we're both doing a pretty good job in how well people do with those stages of disease. And then the truth just being that we don't have a lot of really exciting drug development happening there. The placebo question, which is true across any stage of disease, when you go on to a clinical trial, if it has a placebo-controlled arm, that is part of the consent process. So you're going to be told up front, hey, you could be on a trial, and that half of the people or a third of the people could be getting placebo. And there is no way to know if you're getting placebo if you enroll in such a trial. That's the point of the trial, is to blind investigators and patients to whether or not they're getting the placebo to see if the treatment is better. But in colorectal cancer, the majority of our trials are actually not placebo-controlled. Most of the studies that are being done are actually where every patient is getting something experimental, whether it's done on a backbone of standard treatment or not. And that, again, is part of the consent process. So you will know when you are looking at a study, hey, what is the chance that I'm going to be getting the experimental regimen? Often that chance is 100% that you'll be getting it. And if not, what's the chance that I won't? But if you do enroll in a placebo-controlled trial, that chance exists and you will not know if you get the placebo.
Thank you. I also want to piggyback on that for a minute. Just to what you said, what I've seen also in my research is that it's usually based, like you said, on standard of care. So it's the new drug versus standard of care. So it's not like people are, stage 4 with very little left to do, and they're going to be given nothing or given something. And I think that, that's an important thing for patients to remember. Dr. Marshall, I know that you also do clinical trials.
I'm not sure I have anything to add to the eloquent discussion Dr. Azad just gave. I mean, there is a disappointment often when patients are in randomized clinical trials, when they are randomized to the current standard. They were hoping for the new treatment.
Mm-hmm.
I tend to believe in the randomization gods. I think the reason the study was designed, and often we are the ones designing those studies, is that we don't know if it's going to be better. And there are a lot of clinical trials that turn out to be negative, let's be honest, they don't advance the bar. And so the standard of care stays the standard of care. So we all, the only way though we advance the bar clinically is through clinical trial participation. And, if we look at some of the more successful areas of medical research, HIV,
Mm-hmm.
high percentage back in the day when this was first coming out. Breast cancer, high participation rate. Pediatric oncology, amazingly high participation rate. But when we look at some of our other cancers, and we're one of them, we don't have the kind of participation rate. Now, it's also on us to have in front of patients, as Dr. Azad was mentioning, a trial that's of interest that we want to offer to patients, right? So part of that is a meeting in the middle between the scientific community and the patients. And that's a lot of what, say, the Colorectal Cancer Alliance, that's a lot of what AllyCon's about, is driving awareness, driving pressure, driving funding to our cancer, so that we do always have, as much as we can, a good question to ask, to offer the patients in front of us.
Mm-hmm.
I'd like to mention just one more thing. So people might wonder, why should they enroll in a clinical trial if there's a 50% chance that they're going to get the standard of care? What benefit is it to them? And I actually do think it is of real benefit to be on a trial. So no matter where a trial is conducted, the study staff that run a clinical trial have a much smaller group of patients that they're taking care of. So if you enroll in a clinical trial and you get randomized to getting FOLFOX, for example, you're still going to have a lot of extra attention, a lot of extra detail that's given to you, because there will be a research nurse or study coordinator that really has 10, 15, 20 patients compared to your nurse that is taking care of taking care of dozens or hundreds. And so there is absolutely an aspect of care that I also think benefits people, if that also is something that helps compel people. And that's what I tell people when I say, you might still get standard of care, but you're going to get a lot of extra attention, a lot of extra contact. And I think that also makes cancer and chemotherapy easier.
And you're a card-carrying soldier in the war on colon cancer too, because the data that you provide is incredibly valuable for all of us to learn. So we need that participation for us to learn in advance.
And I think that participation, and I feel a little bit out of place as a surgeon talking about the clinical trial piece, but I will tell you that participation is crucially important, especially in communities like the African American community, where participation has been marginal historically for a number of reasons that we probably don't have time to talk about today. But I think the words that I've heard today have been music to my ears, because it's very encouraging that we can have this dialogue with our patients. But it's also helpful for us to make the language such that patients, especially who already have a certain fear or a certain perception of these trials, don't immediately draw back as soon as the trial is announced. That they feel invited, that they feel that there is a benefit, either if they're getting placebo or not. But I think that's something we have to remember to encourage across the board.
Thank you. There's another question here. How can we improve, backing on to what you said, Dr. McFadden, how can we improve clinical trial access for all? It's hard to navigate through all the clinical trials in this country. And do you always suggest a clinical trial if treatment isn't working? And are they covered by insurance? So I think basically it's you know, I'll let you start. Thank you. Go ahead, Dr. Azad.
So I do not always recommend a clinical trial. There are absolutely, many clinical circumstances where I think standard of care is the right thing for a patient first, depending on what the trial options are. I think, so insurance, some insurances cover clinical trials, most do, Medicare does, but not all. So we make sure that your insurance covers your trial before a person enrolls at Hopkins, and we have about a 90% coverage rate where patients are able to enroll in the study. So the vast majority of times it's covered. Now, the parts that are standard of care will still get billed to your insurance, but the rest of it, insurances will approve by and large. In terms of improving access, this is something that has been a national dialogue for over a decade and persists. It is an extraordinarily complicated question that involves engagement of the community, dealing with trust issues among different marginalized communities, rural communities where academic centers don't exist, and education of not only patients, but doctors as well, because most people with colon cancer are taken care of in community practices that don't open clinical trials. And it puts a lot of burden on patients to have to go to major academic centers and find those trials. And then those are only one study. I mean, John and I are on an email thread with a bunch of people on the East Coast, and that helps, but that's 10 institutions that we run things by when we're looking for a trial for our patients, but there's hundreds of institutions. So I think that problem in itself could be an entire conference that would take a week and we still wouldn't solve it. But there are many of us that are engaged in working on it, and many people in the patient advocacy community as well.
Thank you. Dr. Marshall or Dr. McFadden?
I mean, don't get me started. One of the biggest changes, again, I'm the old member of the panel here. One of the biggest changes that I've seen over my career is clinical research used to be simpler. And it's now very complicated to deliver. There's been an escalation of requirements that's not necessarily really been driven by the FDA. It's driven by the concern that, the FDA might not like what we're producing. And so these things called CROs and other infrastructure that has inserted themselves in the process of clinical research. And so consent forms that used to be 5 pages are now 14 pages. Cost per patient that, requires sponsorship for has, quadrupled in the last 10 years. And not necessarily because the study themselves are more complicated. It's the sort of data tracking that goes along with it. So I think in some ways we're putting ourselves out of business, or we're narrowing the kinds of centers that can produce clinical research because they have to decide to invest in having all of that additional infrastructure. So it is a struggle. And in the last 2 years, just to be very sort of looking at the last, during the pandemic, the great retirement or the great resignation has occurred in all walks of life, and that's true in hospitals and healthcare systems as well. And the people who were staffing our protocol offices decided they would want to do something different. And so we've had a staffing crisis, and I think this is true for many institutions around the country, quite honestly, that's forced us to turn down even our current capacity for accrual to pay for trials. So we have an acute problem on the backs of a longer arc problem that we need to address. I personally think we need to take back control over our research as much as we can and try and re-simplify it. I'm hopeful that the next 10 years we will get some of that.
Thank you. Dr. Azad, there's a question here for you. Last year, you talked about the KRAS vaccine for newly diagnosed stage 4 patients. How's that going? And do you think that there might be data by ASCO GI 2022?
So that is a trial where we created a KRAS specific vaccine that we're able to vaccinate patients against one of the six of the most common KRAS mutations that exist in colorectal cancer. That trial is going well, though because of COVID, we had a 1-year delay. That is a vaccine that we produce at Hopkins. And so our production labs were one of the last to reopen. As you can imagine, we need to take care of patients first. And so we are re-enrolling. We have a handful of patients that are on that study. We are excited about it. It's not just a vaccine. We also give it with immune checkpoint therapy. It will not be presented at ASCO GI, but I hope that it'll be presented sometime next year in 2022.
Thank you. Thank you. So there's some long-term survivorship questions. Some of the general questions are, is there a correlation between chemotherapy and developing non-alcoholic fatty liver disease? You know, what are the best, what can be done about adhesions? I know personally I have many, and every time I went fishing, I ended up in the ER and didn't connect that it was the throwing of and the reeling in the huge fish that was the problem. So, and is anything coming down the pike to help with neuropathy? We'll leave it there and then we'll finish. So, Dr. Marshall, do you want to start?
I'll try with the liver. We clearly see that our chemotherapies do alter liver appearance on imaging. There can be a fatty liver associated with it. Oxaliplatin causes one flavor. Irinotecan can cause another. Some of our other drugs can do the same. So yeah, the longer people are getting the treatment, there is some increased risk of liver dysfunction. I have to say it's not common, particularly when we're talking about patients who got 3 to 6 months of chemotherapy and then are followed. It's not that common in that space. It's the patients who we're also doing surgery on, put intrahepatic pumps in. The more we do to livers, the more worn out they get. But I'm always impressed with just how resilient the liver is. You can do a lot of stuff to it and it keeps on ticking. So the answer is sort of, I think, to the hepatitis question. I'll let others kind of, maybe Cedrek would like to tackle the adhesions.
I never want to tackle the adhesions.
Yeah, come on.
You know, adhesions are, you know, I tell folks all the time, it's scar tissue, you know, and some people make more scar tissue than others. And, you know, I always equate, you know, if you fall and cut your arm or cut your leg, you're going to create some scar tissue as that space heals. And the same thing is true intra-abdominally. There are some things that have been, you know, tried and over the past few years, whether it be the use of intraoperative tools such as Seprafilm, which is a product that can be placed within the peritoneal cavity that, you know, it's proposed to reduce the number of adhesions. That I think the data is not 100% conclusive, but it's one of those things that's been tried. I think the newer technologies such as, minimal invasive surgery, robotic surgery, decreased manipulation of the bowel, that's been a game changer for adhesive disease. You can still form adhesions, but traditionally that's been not as extensive as if there was an open procedure with gross manipulation of the bowel. So, perhaps focusing in on some of the preemptive things that can be done to reduce adhesions. But ultimately, if you have adhesions, operating on adhesions sometimes create more adhesions. So I have to be very selective and sometimes drag your feet on the need to go in to fix that problem, because you can't be creating more adhesions by doing so.
Dr. Azad?
No, I don't think I have anything else to add to that. Yeah.
I mean, we might talk a little bit about neuropathy. No, the answer is no. We don't have any magic bullet for that. What we're trying to do is reduce the amount of oxaliplatin we're giving people. That is the initial strategy. And this has been a fascinating process because we did this huge study, 12,000 patients in stage 3 colon cancer, half of which got 3 months of chemo and the other half got 6, with really the main purpose of trying to reduce neuropathy. If we expose you to less, you're less likely to get it. And the study, depending on your interpretation of the study, it certainly looks similar, right? That between the two, there was some updates in the recent journal that younger people don't do as well as we thought. But nonetheless, we can give less. So the answer really from the patient base is that many general oncologists perceive that the correct number somehow on the Moses tablets was 12 cycles of treatment or 6 months. And, there's lots of evidence now that that is not a magic number, that 3, particularly even in metastatic disease, 3 to 4 months may be the right initial duration of treatment with the oxaliplatins. And adjuvant disease, some patients might need more than 3 months, but 3 months is sort of the base, in my opinion. So get less oxaliplatin, more is not necessarily better.
Thank you. So we have a few minutes left, and I would like to ask everyone, what is the most exciting development you've learned of in the colorectal cancer space? Dr. McFadden? We'll start with you.
No space to think about that one. I'm as a surgeon, we operate and we take care of cancer, and then I think it may not be a direct development, but it's the energy of, well, at some point, rectal cancer be a medically treated disease. Will I no longer have a job to operate on rectal cancer? And obviously, I think there'll always be a space for a surgeon to operate. But I do think that's an interesting thought to ponder and to think about and to, I think, explore. I think we know that rectal cancer is a tough disease, and that would be a win for I think all of us. But I do think that's an interesting thing that's on the horizon. I'd be interested to hear their thoughts on that as well.
Thank you. Dr. Azad?
I am very interested in the data and knowledge that we've gained in the last 5 years on the biology of colorectal cancer. So there has been a massive explosion in the complexity of technologies that we have to examine nuances of colon cancer biology. So it's not just KRAS mutated or BRAF mutated now. It's being able to look at hundreds of genes and how they're expressed in different proteins, and what it means and what the immune interaction is. So I think that area is extraordinarily exciting. It has not had clinical utility yet. So what has happened is that we have all this data and all this information, and what I think in the next 5 years is going to be really, really compelling is how are we able to take all of this big data and use it to treat patients better, possibly to treat a whole bunch of patients less, like John was just saying. There's a lot of people that are going to do well, and we should be able to figure out who those people are without over treating them. And then how can we come up with new therapies for some people based on some of this information.
Thank you. Dr. Marshall, last but not least.
In 20 seconds, we've got, it's both the good and bad, that young people getting colorectal cancer has woken us up to reinvest, to double down, to understand what's going on. Racial disparities, the recognition of racial disparities in this space, and then couple that to sort of research in microbiome. I am hopeful that this new money, new understanding, or new observations, and a new area to study in the microbiome will in fact make the next 10 years maybe our best 10 years yet.
Thank you. I just want to thank all of you for participating in this panel. It was very exciting, and I hope that everyone has learned something from it. And until the next time, thank you all very much.
All right, thank you.
Thank
Bye-bye.
Thank you.
Bye-bye.
Bye, everyone.
Bye.
Bye.